in the absence of any more questions, we'll move on to the next and last speaker. Will be Dr. Stephen Cates. Dr. Cates is an orthopedic surgeon who is currently the chair of orthopedics at VCU in Richmond. Dr. Cates is really the father of the idea of collaborative care between ortho and geriatrics, which is called ortho-geriatrics for hip fracture patients. And he's really been the thought leader on this concept around the world. And his model is now being adapted almost everywhere. So Steve, again, thank you for participating and look forward to hearing about this treatment paradigm.
Thanks very much, Paul. So I'm going to talk a little bit, as Paul said, about ortho-geriatric fracture care. And this is a topic near and dear to my heart. These are my disclosures. I don't think anything here of negative disclosure. I serve on the Own the Bone committee with Paul and with Andrew. So I'll talk a little bit about some concepts for an organized program and how it works, standardizing care, some of the patient flow and results. Really, our goals with ortho-geriatric care are to reduce the morbidity and mortality, reduce the length of stay, reduce the time to surgery, and improve quality of care. I'll point out at the beginning of this talk that it's my understanding that U.S. News and World Report will be using this for quality judging of our hospitals, so it probably has more value now, even from a standpoint of that, than it had just for excellent patient care. So there's some important principles. I was thinking a few nights ago, what's really important to share in a short talk, and I keep coming back to communication. It's really important to communicate well. This pandemic has made it harder to communicate. People don't see each other as much in the hospital. They're wearing masks. People don't talk to each other as much. I think some people are working from home more than in the past. So communicating with one another is really important. Using lean methods to improve the outcomes has been a focus for years for me, and I think that this continues to offer benefit. Co-managing the patient with orthopedics and a medical consultant, such as a geriatrician or a hospitalist, is a key for success. And then having what we've termed in the past patient-centered, protocol-driven care. And in the past, everyone asked, what's this patient-centeredness? And now everybody talks about it. But having the protocol-driven care is much easier now with Epic and other EMRs, where you can template the order set into the electronic medical record, and it becomes the easiest thing for the surgeon or the resident to use. And you can template in best practices, most importantly. So setting it up so that it's collaborative and interdisciplinary. Every hospital has multidisciplinary care, but interdisciplinary care is where people actually work as a team. That's really hard to change that culture. In many places, the consultants don't want to write orders and don't want to take much responsibility. So if people share the responsibility, the patient gets a better result. You have to include the social workers, the therapists, the nurses, patient care techs as part of the team. And one of the important concepts is planning your discharge when the patient's admitted, getting a rapid pre-op assessment, early surgery, as Andrew mentioned. A joint patient ownership, this requires some culture change. And all of this leads to a collegial environment, which is nice. So communication, particularly in between the physicians, the APPs, and the physicians. And of course, if there's a family around, talking to the family is important. A lot of times they will disappear after the patient gets admitted. So it's important to make contact with them and explain the plan early. The patient often has delirium, so they don't remember what we talked to them. And then periodically talk to your hospital. This is really what Andrew was talking about, and emphasize the benefits of having a good program so that they are supportive of it, either economically or it stays somewhere on their radar screen. When you develop your protocols and your order sets, it should be co-developed. I don't know that there's any perfect way to do this. I've certainly been at it a long time now. Since 1995 I've been doing this, but you have to agree on what's your local best practices, and sometimes that requires compromise, and the goal should be to avoid errors. People should be fast-tracked through the emergency department. Basically, the fractures identified, labs are drawn, and essentially nothing else should be done in the ED other than maybe a fascia iliaca block. Nothing good's going to happen in the ED to a geriatric patient with a hip fracture, so they should just get admitted, plus or minus that block, and it should be really a one phone call system. The goal of a medicine consultation is to optimize the patient, make sure they're comfortable. Fluid management means hydration. Every hip fracture is dry. Unless they were in the hospital in CHF and fell out of bed, 100% of them are dry and they need to be hydrated. We have all sorts of new anticoagulants. A lot of them look like they're fun, based on the TV commercials that we see on TV about how much fun it is to be anticoagulated. Of course, it's not fun for us as surgeons. So figure out which anticoagulant they're on, and then they may need to be managed. Some of them you can ignore. It's important to set up goals of care. So if person's really at the end of their life, get your palliative care team involved early. A functional assessment will really predict the outcome of the patient. So if the patient is community ambulator and they're out shopping for themselves or playing golf or doing other community activities, they're going to do much better than the bedbound nursing home patient. The bedbound nursing home patient is going to have a miserable prognosis. And then medication management, again, this has been made, in my opinion, it's been made easier by Epic or the other EMRs. You can basically just go through and discontinue all the bad meds. So I did this to one of my own patients yesterday morning who had some delirium. Basically open up the medication section. All the medicines that are anticholinergics or psychoactive meds should just be discontinued. It doesn't make the patient worse, it makes them better. So just stop all those meds. The geriatric consult should also coordinate any other medicine consults like cardiology, and you shouldn't really get many of these. Again, stop the bad medications. So if you want to shorten your length of stay, you have to sort of lean out each of the steps, rapidly optimize the patient. You have to have OR time. That is a current problem at many hospitals with our shortage in nursing staff, which has made availability of ORs reduced. Obviously, the physicians need to cooperate. You should avoid delirium, avoid complications. And then if they're going to go to a rehab, the bed's got to be available. If the bed is delayed 48 hours, and I have a current inpatient where we have to wait 48 hours for a bed, then your length of stay is 48 hours longer. So it's that sort of thing that is frustrating. So timing, basically, Andrew said it earlier, it should be done in under 24 hours. This means prompt medicine evaluation, prompt surgery. Shorter is better. And I personally feel these patients should be put at the front of the trauma list, not at the end. I'm sure there's a lot more interesting cases, but most of those patients will do better in 30 days and 1 year than the hip fracture patient. So doing the surgery early and at the front of the list is important. Andrew said this already, but I think I'll repeat it because people don't do it. A metabolic bone workup on admission is important. So take the family history, take the medication history, find out if they've been on any treatments. We do measure a calcium, 25 hydroxy vitamin D, the PTH level, of course, the complete metabolic profile, and then we're trying to find out what they've taken in the past if they remember. This is that teachable moment that Andrew referred to. So telling the patient you have osteoporosis, this is the time to do it. Tell the family, tell them they're going to need follow-up treatment in your FLS clinic, and explain that we're going to try to help them prevent future fractures. This is the time to do it. For anticoagulants, it's safe to reverse warfarin. We've published on this. As long as you get it to 2 or less, it seems to be fine. You should set a target of 1.5, but getting it under 2, it usually is fine. You can give oral vitamin K. It works better than IV, and it's safer. If you're going to use fresh frozen plasma, run it right as you're starting the surgery. Don't start it 6 hours before because it's worthless and it's gone. All it does is fluid overload the patient. Plavix, we ignore any of the Plavix type drugs, Brilinta, Plavix, any of those, we ignore them and just do the surgery. And then the direct anticoagulants, those may need a little longer time to reverse as they don't have a good antidote. The enhanced recovery after surgery program is very helpful to add to your hip fracture patients. So you only have a short time to optimize them pre-op. We've talked about that a minute ago. Allow the patient to drink the carbohydrate-rich liquid. That's also, Gatorade type of drink up to 2 hours pre-op. Avoid using too much opiates, and early post-op mobility is important. You can cut your infection risk with these patients and basically decolonize them. So it's chlorhexidine, washes preoperatively, nasal mupirocin. You could also use a nasal betadine big Q-tip. And then we also use the chlorhexidine mouthwash. It's called Paradex. We wash the mouth out as well. Those things cut your infection rate post-op, and it makes a meaningful difference if you do this in all your patients. About 61% of the patients are going to get some delirium. So the online statistics that say it should be less than 5%, that statistic is put together by someone who's not living in the real world. This is often not recognized, but if you look for it, it's there. The patients are a little confused. They forget where they are. There's 2 types of delirium. There's the type that is hyperactive, where they're crying out and trying to get out of bed and ripping out their lines. And then there's the type where they're quiet and you go in to see them in the morning and how are you? And they may answer appropriately, okay, close their eyes and fall back to sleep. That's hypoactive delirium. Delirium's bad. It causes complications and it may remain after hospital discharge. So it's best to try to find the cause and help clear it. Gentle reorientation, particularly retain the glasses and hearing aids, is important. Delirium increases your length to stay. It reduces the functional status. They don't want to do the PT when they're delirious. It's very scary for the patient. They'll get pressure sores. They're incontinent. They'll fall. All sorts of bad things happen. Aspiration pneumonia. So only about a third of the hospitalized elder patients recover fully from delirium. So this is bad. Try and avoid it. So if they've had it before, they had it at a prior hospitalization, it's much more likely to recur. Cognitive dysfunction before coming in the hospital, in other words, some early dementia, predisposes to delirium. Of course, the elderly patients are more likely than the younger patients, people with a lot of medical comorbidities. Polypharmacy is probably the biggest risk factor that you can fix by just stopping all the bad meds. The bad meds are the benzos, the anticholinergics, antihistamines, so forth. The easiest thing to do is let them wear their glasses and their hearing aid. Do not take them away. Tape them onto the patient. They'll be less likely to get lost, not more likely, and they'll have less delirium. So early surgery helps avoid delirium. Again, less than 24 hours. I personally love early surgery, even like 12 hours. So if you can get the patient in, hydrate them, check them over, they're probably not going to be any healthier than that. Use your enhanced recovery after surgery principles. Keep the glasses and hearing aids on. It looks weird during surgery to have them taped onto the patient, but it's fine. It's safe. Don't tether them down with multiple things. Don't use restraints. Having the family present and talking to the patient if it's possible, if your hospital allows it with the pandemic, that's really important. Mobilize them early, get them walking immediately. We try and get the patient up right as soon as the spinal is worn off. And then good pain control, minimal opioids, consider a nerve block or nerve blocks to relieve the pain. Most patients don't need an echo. There's specific AHA, ACC guidelines for this. Basically, if they have an uncontrolled arrhythmia, they have aortic stenosis, they have bad congestive heart failure, they have an acute MI, they may need an echo. That decision should be made by your hospital or geriatrician with a cardiologist. Otherwise, don't even consult cardiology. Most cases don't need an echo. It's rare. Anesthesia, really having the patient risk assessed and have things optimized ahead of time is good for the anesthesiologist. It reassures them. Anesthesiologists fear being blamed. So if things are really documented well and you have good quality of consultation, it makes a difference. We recently published a paper in the New England Journal showing that spinal and general have clinical equipoise. That's a regain trial. So although most of us thought spinal would turn out better, it turned out to be pretty much equal. One thing that does matter is avoiding intra-op hypotension. You can avoid this by tanking them up with fluid prior to surgery. So they are dry when they come in, give them crystalloid, and help avoid the intraoperative hypotension. And again, functional capacity predicts their outcomes. So if they were healthy and active, chances are they'll have a better outcome than the nursing home patient. When they get to the OR, you want them optimized, not febrile, skin healthy, and you can do the surgery. There's a right and a wrong way to fix the hip fracture. This is my cookbook approach to doing this. Basically, if you follow this approach, you're not going to make mistakes. To me, it's pretty black and white. People getting creative with hip fracture fixation make mistakes. Basically, when you're in surgery, keep them warm. You want them about 37 degrees, using a warming blanket and, if necessary, fluid warmer. Warm the room up a little. I know we hate that as surgeons, but that's beneficial. Position the patient carefully. Don't tear their skin. Give them antibiotics, correct weight-based dosing, and use the poster that I just showed to do the right surgery. This is really not up for discussion. You have to do it right. So using a stable construct that allows weight bearing is tolerated is key. If the patient cannot bear weight right away, then you did the wrong operation. Post-operatively, again, use the protocols, follow the standard order sets, and work with the team to get the patient moving. We weight bear them on the day of surgery. So as soon as the patient gets up to the floor, therapy sees them and gets them up, gets them walking. You have to be able to weight bear is tolerated after hip fracture. Otherwise, they end up in a chair or in bed. There is no partial weight bearing or toe touch weight bearing. That's ridiculous. Knee braces shouldn't be used. It's another tether. So I haven't used one in years. Multimodal pain control, as long as it's not going to cause problems for the patient, renal wise or something that is preferred. Aspirin or low molecular weight heparin are pretty typical for 28 days for DVT prophylaxis. Make sure they're not tethered down. An oxygen line is a tether, the IV is a tether, the Foley is a tether. Try to avoid these. And if possible, give the person a regular diet. Discharge planning, the patients often go to skilled rehab. Some of them can go home, some of them go back to long-term care. Really, your goal is a 3-day length of stay. And working with the social worker and talking to the family is important. Again, we have so much disruption in the healthcare system right now that this is sometimes hard to achieve, but it should still be the goal. So thanks for your attention. I'm happy to take any questions and appreciate your invitation tonight for me to speak.
Steve, thank you very much. And you really should be congratulated for bringing this entire program to the world. And it's impressive how widespread this is being adopted. There are, like with established FLS, a lot of problems trying to get buy-in from this program from everyone. One of the stumbling blocks we've had is about the pain control, and you recommended using the fascial iliacus blocks. Maybe you could just explain what that is and what that does, because most of the people in the audience probably aren't familiar with that. And do you get that repeated for post-op pain relief?
Right. So the fascia iliaca block can be done by your anesthesiologist, by an ER physician. In Europe, they're done by the EMTs. It seems to be a pretty safe way to do it. It's given in the iliac muscle fascia. It's injected in most cases these days using an ultrasound machine, and it numbs up the nerves that are going to cross the hip joint and relieves much, probably not all, but much of the pain that the patient's going to experience. So yeah, as you know, the nerves are coming out of the spine. They will cross the anterior iliac fascia and the pelvis, and it numbs them up a little, numbs up the nerve roots, and they have some post-op pain relief. If you give it right before the surgery, they'll have some afterwards. It's best to give it right when they come to the hospital. Can it be repeated? I haven't seen them repeated, but it can be. We will occasionally have someone in a lot of pain post-op, but usually fixing the fracture early gets rid of most of the pain. So giving the patient a spinal or a general anesthetic with a fascia iliaca block, it seems that they have pretty good pain control. So I don't usually see them repeated post-operatively, but it could be.
Yeah. Thank you. Dr. Shaker, you have a question?
Yeah, Steve, that was a great talk. I really enjoyed it. As a non-surgeon, I enjoyed it. But I have two questions. One is, why are they so volume depleted? Is that because they've lost fluid at the fracture? And the second question is, how often is a delirium due to electrolyte abnormalities like hyponatremia, which often occurs in people with pain and nausea and so forth?
Okay, so I'll take those separately. They're typically volume depleted for two reasons. First of all, most of the time this happens in the middle of the night when the older adult's going to the bathroom. They don't have the night light on. They may have a throw rug or some other obstruction between them and the toilet, and they trip and fall and they break their hip. So in the morning, they're found in a pool of urine on the floor. So they've been laying on the floor all night, and there is bleeding from the fracture. People can actually bleed to death from a proximal femur fracture, particularly the subtrochanteric fractures bleed an awful lot. So there's a lot of fluid loss in the form of just whole blood that pours into the thigh, and then some of it is that they're dry because it's in the middle of the night, and they've, just like the rest of us are dry when we get up in the morning, they're dry. So almost all hip fractures are dry when they come in. It's very, very, very rare to see one in congestive heart failure. Again, unless they're an inpatient on the medicine service being treated for it. I can't remember having seen one in the last 10 or 15 years. The second question you asked, sorry, could you repeat, Joe?
Was how often electrolyte abnormalities cause hyponatremia, contribute to delirium in a person who has other risks?
Yeah, so I think that there's a lot of things that can contribute to delirium, and we don't really know. I mean, there's probably some cytokine basis for it. They think that that actually causes it. Of course, we'll find out one day that all the stuff we're talking about right now is wrong, just like much of what we learned in med school is wrong. But I don't know that the electrolytes, the major cause. They seem to, the most common cause is taking away their glasses and hearing aids, pain, and just being put into an unfamiliar environment where they're staring at the ceiling tiles. They're tied down. It's blurry because you took their glasses away. They can't hear anything. And I think that all of those factors, plus any bad medications we give them, promote delirium. Again, I think there's some actual science to it that shows there's a cytokine release into the cerebrospinal fluid, and that's probably more along the lines of what we're gonna see that's the real cause. But I too see a lot of these folks post-op have low electrolytes. They're hyponatremic particularly. I'm not sure that that's the cause. The one thing not to do to these folks is send them for a head CT. So unless they have a actual visible head trauma, their head split open, or they have a big bruise, I forgot to mention this in my talk, don't send them for a head CT if they have delirium. They don't need that. That's just bad medical care.
Thank you.
Yeah. Okay, again, thank you very much, Steve. That was a really excellent talk, and certainly something for everyone to aspire to. You did mention you did do PTH and vitamin D and calcium initial screening, which I presume is in the emergency room. You order those labs drawn. I don't know, maybe Dr. Binkley or Joe could comment on whether those are valid tests in the face of someone who just broke their hip.
They're not.
Even PTH?
I doubt it. But clearly 25-hydroxy-D is going to be low. There's really pretty good evidence that inflammation acutely reduces measured 25D. So you're going to get a low 25D and you're going to give them vitamin D, or you can assume that they're vitamin D deficient and give them 25D and save the lab costs. To get an accurate 25D measurement, it's best done when they come back for their 6-week follow-up.